Good. Welcome everyone to today's broadcast on self-care interventions for sexual and reproductive health and rights, contributing to WHO's triple billion targets. And this is sponsored by WHO's Department for Reproductive Health and Research. And my name's Ed Kelly. I'm Director for Service Delivery and Safety in the same division now as our colleagues in reproductive health and research. But I direct a group that handles services and safety and works to advance the quality and safety of those services, as well as is the owner and sort of promoter for WHO's framework on integrated people-centered health services. And this whole concept of self-care has become very central to our work in health services, not just in reproductive health services. But I have the honor of talking through with you today some of the framing for this particular seminar, and then also to be our moderator and introduce our different panelists. So if I could just go to the next slide, I'll just frame slightly the issues of the questions on self-care in a broader context of WHO's own work on addressing the Sustainable Development Goals and our own work on the triple billion targets that we have promoted here at WHO as part of our work for our new general program that is multiple years worth of work and involves a big shift in WHO's thinking on how it will deliver on the Sustainable Development Goal agenda and how to assist countries in this. For one, when we talk about the triple billions, for us, this means three pillars of work around universal health coverage, around health emergencies, and around healthier populations. And the billions refer to a specific target put forward by WHO and our new leadership, Dr. Tedros, to achieve $1 billion people. First, benefiting from universal health coverage. Second, who are better protected from health emergencies. And third, who are enjoying healthier lives. And this is part of a general shift that WHO has made in its work leading the world and advising countries on health policy and providing normative guidance to the world on all sorts of health issues, to also push for greater delivery at the country level and achieving the Sustainable Development Goal agenda. And the idea of putting a number, and a big number at that, on these three goal areas is part of what we have put forward as a new shift for WHO to look at measurable impact on strengthening our partnerships and really putting forward the country and the country offices and our work with national governments as the highest priority for the organization. The work will no doubt be interesting in terms of measurement, and I think that one of the key themes that we have today to explore is how can self-care help us achieve these goals. In particular, it's highly relevant for the work on universal health coverage. There is no way WHO or national governments will walk or drive or fly to every village in the world in order to achieve access to health services. And WHO's own work on people-centered health has focused on the idea of engaged, empowered communities, families, and individuals who are at the heart of this work. WHO's work for last year's 40th anniversary of the Alma-Ata Declaration, which took place in Astana, Kazakhstan, and came out with a new Declaration of Astana, put this definition of the primary health care approach forward, which is quality primary health and public health services supported by multiple sectors and serving engaged and empowered communities, families, and individuals. And so this will be one of the key pieces. How self-care fits into that is one of perhaps the most important questions, but also one of the least examined at WHO in terms of our evidence base and in terms of some of our operational work. So we'll look forward to this seminar as the first step on that. And on the next slide, I'll just show the outline that we have, which looks at our colleagues from different parts of both WHO and also outside partners who are going to present some of the findings we have on in terms of conceptually, as well as the look at the legal, the cost and benefits, as well as humanitarian questions and waste management, and will come immediately to our colleague Paul Simpson, who will frame it for us for the look at BMJ's work with us on this, which we're really looking forward to coming up shortly on that. Just before we begin, on our next slide, I'll just remind you that we are in a webinar with a whole bunch of people, so we'd ask you to submit your questions anytime online, and what we'll do is Q&A after the presentations. Our colleagues managing the webinar will be forwarding those to me so we can get those to our panelists and try to answer as many as we can, and certainly we'll follow up afterwards. The webinar is also recorded, and we really encourage you to visit the website as it's listed up there to see some of the additional materials. So without further ado, maybe I go to the next slide and just introduce Paul, who is BMJ's international editor and was the editorial lead for the recent collection on self-care interventions for sexual and reproductive health rights. And Paul has an illustrious career working in a number of different editorial areas, and it's my honor to turn the floor over to him. Paul.
Thanks very much, Ed. As Ed just said, I'm the international editor for the BMJ. And as we've just heard, and we'll see over the next hour, there are a few healthcare approaches that sit as comfortably across the triple billion goals as self-care. And so given the importance of self-care for sexual and reproductive health and rights, it's only natural that the BMJ and the BMJ Global Health were interested in supporting a collection of articles on this topic. If we could see the next slide, that would be great. So all of the articles that are covered in today's webinar and tomorrow's webinar can be found if you go to the URL that's at the bottom of the screen here. And there you'll find there's an editorial, there's 6 analysis articles, there's 4 opinion pieces, and 3 systematic reviews. And there are 2 or 3 more articles to follow, and they'll be added to that page as they're published. So the analysis articles and the systematic reviews that are peer-reviewed, and all of the articles are open access. So they're free for everybody to read, to download, reuse, and share. In the collection, it represents a huge amount of work from all of the authors, and I'd encourage all of the attendees to explore it. And if you wanted to reflect on any of the articles or kind of write a comment, then what I'd encourage you to do is write a rapid response. So on each article, there's a tab at the top, which you can click on and write your response. It's a moderated process, so it might take a day or so for the comment to go live. And there's already 4 or 5 responses to the articles in the collection. So I wanted to briefly highlight 3 themes that I saw emerging through the collection and that you'll hear in today's webinar. The first is the challenge of writing about self-care, because it's a vast topic. It ranges from things that people do that they might not even consider as self-care, so eating, exercise, and learning, to a set of interventions that are clearly designed as a self-care task, so self-testing kits or using an app on your phone. And then a further challenge of communicating about self-care is the perspective of the reader, which is crucially important. So that might be the perspective of a self-carer or the perspective of health professionals. So communicating about self-care is quite a skill. And I think the first talk that Manjula will give and the accompanying paper is really helpful in providing a conceptual framework for thinking about self-care. And it's really helpful in framing discussions about self-care. Another very important theme that came through in the collection, and I think is reflected in the 3 middle talks of today, is that really self-care shouldn't be thought of as a replacement for sustainable and high quality health services. It's not a shortcut to universal health coverage, but it's a complementary component of healthcare. And finally, I think that the nice thing about this collection is it really shows the Sustainable Development Goals in action. And I think that's represented in the final talk that we're going to hear on the environmental impact of self-care. And I think that a few years ago it would have been rare to see an article like this in a collection on health. So it's really very welcome to see an article on the impact of the environment covered here. So to summarize, the three themes that are emerging are the challenge of communicating about self-care. It's very hard to do so, but it's critically important that we can. Self-care isn't a shortcut to universal health coverage, but it's a complement to high-quality healthcare. And we need to consider the environmental costs of the interventions that are developed. So finally, before I just hand over to Manjula, I'd just like to thank the BMJ team and the BMJ Global Health team who helped pull this together, and actually the work of the authors, because it was a huge amount of work that many authors put into pulling this collection together. And I'd encourage attendees to explore the collection. As I said, it's open access, so it's freely available for everybody to use and read. And I'm very much looking forward to hearing the rest of the talks in today's webinar. Thank you.
Great, thanks for that. And I just now would like to, as we said, bring back the microphone to Manjula, who will take us through some of the framing on the self-care within a framework of normative guidance. Manjula is a colleague of mine here at WHO, and she coordinates the normative guidance on self-care interventions and has done a number of other areas of work here at WHO, but this is a big piece of work for her. So over to you, Manjula.
Hi, thanks very much, Ed and Paul, for that frame. Thank you. So, as Ed just mentioned, I work on developing the normative guidance here at WHO, and the context of the papers that are in the supplement and that will be presented on the webinar today and tomorrow have actually look at new evidence which will inform the development of the WHO guideline on this topic. And so the goal of the normative work is really to develop people-centered, evidence-based guideline that encompasses both existing and new WHO recommendations and good practice statements around self-care for SRHR in particular. And we used a broad consultative process to develop the conceptual framework and terminology for this work. And but we acknowledge that self-care is not a new concept. You know, we know that people have been and they continue to practice self-care, you know, various different kinds of self-care and around the world. And what is relatively new here is the recognition that self-care is also important to health policy, especially where it intersects with health systems and with health professionals. And there are many examples of this, and Paul earlier mentioned a few of those examples, but examples of health interventions that were previously available only through facility-based healthcare providers, and there are now transitions to being accessed in self-care environment, is something that will be the focus of the WHO guideline. And in this space, the self-care can range from HIV self-testing to self-management of abortion to taking pregnancy testing. Next slide, please. So the World Health Organization's working definition of self-care, which I will come to in a little bit, you know, shows various aspects of what we mean by self-care. And as I mentioned, there is self-care in the context of health systems and in the everyday life, and people use various terms, self-management, self-medication, self-testing, self-treatment, and all of this we encompass into the concept of self-care. So next slide, please. And so the working definition includes the ability of individuals, families, and communities to promote health, prevent disease, maintain health, and cope with illness and disability with or without the support of healthcare provider. And the scope here includes health promotion, health disease prevention and control, self-medication, and providing care to dependent persons as well. Whether you seek hospital or specialist care, if you need to, and also rehabilitation, including palliative care. And we know that there are many, many global initiatives now that are starting to recognize the importance of self-care, including in primary health care, and also for the universal health coverage, as was previously mentioned. So self-care in this context can really meet people's needs throughout their life course, as well as give increased autonomy and agency to individuals, but also to their families and to their communities to optimize their health, not only as advocates for the policies that promote and protect health, but also acknowledge them as co-developers of health and social services, for themselves as self-carers, but also for them as for those of the people who are also caregivers. And there's also a growing globalized market of drugs, of diagnostics, of devices, coupled with really rapid advances in digital technologies and mobile platforms. And this is making new configurations of self-care possible. And many of these interventions will be regulated, and we know that many more will not be. And because of this increasing number of new interventions, the importance of linkage to care and the supportive part the health systems can play become really important. And it's also therefore really important to get that clearer conceptualization of what we mean in terms of self-care to support health policy. And that's where we worked on developing this the conceptual framework. And next slide, please. And in this conceptual framework that we're proposing, we're putting the individuals at the center. And we're putting them in the center in the context of key principles of human rights, of ethical considerations, of gender equality, and a holistic approach to health across the life course. And this framework also acknowledges that people increasingly access health information and interventions and products outside the formal health sector. They're going to the internet, or they're going over the counter at pharmacies, or they're getting information from their peers. And the framework recognizes that, particularly for vulnerable populations, that a supportive and safe enabling environment really becomes very important for the introduction of self-care interventions, and that these should be implemented in the context of, for instance, supportive legal and policy environments. And so this means that there's the need for justice, a strong and accountable, people-centered healthcare system, and integrated and accessible services that are of good quality, that people are protected from violence and coercion and discrimination, that there is social inclusion and acceptance, and the knowledge and the information that they have is appropriately tailored to the different needs. And the last circle of the framework talks about accountability, and the accountability for the health outcomes is reflected here at multiple levels. But the accountability of the health sector really remains a key factor in the equitable support to quality self-care interventions. And while self-care is important in all aspects of health, the series of papers in the supplement are focused on SRHR because self-care is particularly important and challenging to manage for populations that may be negatively affected by sex, political, cultural, and/or power dynamics. And we know that this is true for sexual and reproductive health and rights, where many people are not able to have autonomy over their body or to make decisions around sexuality and reproduction. So this supplement focuses on examples from SRHR, putting an emphasis on self-care as a positive choice, even for the more vulnerable populations. And self-care should really, therefore, not be born out of fear, out of stigma or coercion, or because there's no other alternative health care. So coming back to WHO's triple billion goals, achieving this is not going to be straightforward, and we know that. But reorienting formal health systems to positively engage with self-care, we think could make a substantial contribution. Thank you so much.
Thank you so much, Manjula, for that and for framing the issues around this conceptual model, one of the foundations that we'll need going forward. If I can turn now to Laura Ferguson to speak about some of the legal and human rights aspects of this. We're really pleased to have Laura. She's an assistant professor of preventive medicine at University of Southern California and director for the program Global Health and Human Rights at the USC Institute on Inequalities in Global Health. And she's got a lot of experience in different parts of the world, particularly in sub-Saharan Africa, working with this at the front line and seeing how self-care can really make a difference. So Laura, can I turn over to you, please?
Thank you very much, and good morning, everyone. I'm Laura Ferguson. I'm going to talk a little bit about the human rights and legal dimensions of self-care interventions for SRHR. And we've just heard from Manjula about the potential of self-care interventions to improve access for hard-to-reach populations and to reduce the burden on overstretched health services. But we have also heard about the potential for misuse and possible harms for users, which also has to be considered. And what we found is that a human rights and legal analysis can really highlight potential concerns in order to help inform the enabling environment that's needed to truly promote appropriate and equal access to quality self-care interventions, especially for people in situations of vulnerability. Next slide, please. As has been mentioned, most of this work is based on articles that are forthcoming in the BMJ. This is actually came out yesterday. So I wanted to thank my co-authors before I go any further, Susanna Freed, Tabu Matsaseng, Sundri Ravindran, and Sophia Gruskin, who also all contributed to this work. Now, we know that a lot of human rights are relevant to promoting and protecting sexual and reproductive health, but some have been widely recognized to be particularly important. And these rights that are listed here can form a human rights framework for assessing the rights dimension of self-care interventions. And just to flag, this is a different framework from the overarching conceptual framework that Manjula just presented, but it kind of is nested within it, focusing on the human rights aspects. And although each one of these is incredibly important, in the interest of time, I'm not going to go through all of them. But I do want to talk quickly about the right to health, because it encompasses a lot. For the user, the ability to engage in self-care interventions that are available, that are accessible, and that includes financial accessibility, that are acceptable and that are of good quality is absolutely key. If we flip that from the perspective of the duty bearer, and that's usually a state actor who has an obligation to respect, protect, and fulfill human rights, the right to health should form the basis of any laws, policies, and regulations governing self-care interventions. And the only other piece that I want to flag in here right now is the right to information. Because when we're talking about access and use of interventions outside the health system, people must have enough information to make informed decisions. And so in this context, the right to information relates to how the provision of information is regulated, including where liability falls for inaccurate or false information. And that's particularly important when talking about self-care interventions for which users seek information themselves, often relying on what's publicly available rather than health professionals to make appropriate decisions around both self-care and when to seek services. Next slide, please. So the legal and human rights dimensions relevant to self-care interventions, they vary by intervention and by location. And so on top of the human rights framework you just saw, there are a few overarching considerations that, when systematically addressed, can also help us understand the safeguards that might be necessary for rolling out these interventions. Again, I'm not going to go through all of these, I'll just mention a couple. First of all, I think the assessment of the legal environment, including laws criminalizing certain behaviors or fostering discrimination, can really help identify approaches that can ensure safe access to and use of self-care interventions. And that would include also functional mechanisms for redress when required. Another key concern that's already been mentioned a couple of times is that self-care interventions may contribute to people becoming disconnected from health providers. And to note that there's a real difference between people using self-care who know they can connect to a strong health system if required, and people using these interventions because the health system isn't available to them or doesn't meet their needs. And it's really important that self-care interventions be an adjunct to, rather than a replacement for, interaction with the health system. And finally, some self-care interventions might be expected to be reasonably safe and increase access without imposing additional burdens on the health system, whereas others are potentially more harmful, especially in the absence to appropriate linkage to care. And so an in-depth analysis of the different social, economic, and political contexts of individuals and communities, as well as the potential benefits and harms for different users, is critical to creating the enabling environment for self-care interventions. Next slide, please. So, to dig a little bit deeper into the human rights aspects of these interventions, we looked at the human rights dimensions of self-injection of hormones for two different purposes and within very different legal and social contexts. The first is self-administration of prescribed hormone treatment for assisted reproduction, and the second is unprescribed, medically unmonitored hormone treatment for gender affirmation. And we obviously used the whole human rights framework that I presented, and again, I'm just going to pull out a few illustrative findings here to give you a sense of the work. In terms of the right to health, and I'm looking first at assisted reproduction, most women can access hormones through health services, even as there may be some insurance restrictions. But these restrictions could actually constitute discrimination, such as in cases where access may be determined by age, marital status, or sexual orientation. And these regulations vary widely by country, but for any woman whose access is restricted, they may have no legal avenues for recourse if they wanted that. But let's compare that briefly to the situation of trans people using hormones for gender affirmation. We know that the use of hormones for this purpose generally improves psychological health and relieves physical discomfort amongst trans people, but it's usually not covered by insurance, which can make it inaccessible. Also, in a lot of places, trans people have to get a mental health diagnosis to access gender-affirming care, which violates their right to health. So a lot of trans people access hormones through the black market and self-inject without medical supervision. And this is also partly because of the discrimination they face from health workers when trying to access services. So if they're accessing hormones on the black market, who's accountable for the quality of the hormones, and where can they turn for help in case of complications or adverse reactions? So we have this situation where in both of these situations, users want to be able to self-inject hormones safely and with appropriate information and support. But the challenges they face are different, and the interventions needed to promote safe access are also different, which is really important for countries to understand. And obviously there's a lot more in-depth analysis in the paper, but hopefully this gives you a sense of why such an analysis might be useful. Next slide, please. So just in conclusion, very briefly, we have to balance the potential benefits of self-care against potential harms, including potential rights violations, and that self-care interventions should only be introduced where there's adequate health system support, so that these are an option but not the only means of access for people. And really, I think my overarching point is that assessing and ensuring an enabling environment in which self-care interventions can be made available safely and appropriate has to be the cornerstone of any strategy to introduce or expand the use of these interventions. And a human rights analysis can help identify actions to ensure safe and effective provision of self-care interventions for all potential users. Thank you.
Great, thank you so much, everyone, and Laura, for that. If I can just building on that framework in terms of the legal the framing of this, I'd like to turn now to David Wilson, who will give us a picture of this on the cost, benefits, and financing of this type of self-care question. David is program director in the World Bank's Health Population Nutrition Global Practice and leads the bank's Global Solutions Group in support of health systems strengthening for UHC, as well as the Decision Science Initiative focusing on data science, technological innovations. And David and the bank, of course, are longtime partners of WHO, and this is for big organizations like ourselves is a new area that we're really pleased looking at together. So David, just making sure that your audio was working, I'll pass it over to you. Let's see, David, I'm not able to hear you so well. Can we just try one more time there? Yeah, David, I guess we are having a bit difficulty hearing you. Maybe the best thing for us to do is to see if we can get your the audio fixed there. Yeah, David, can you hear us? No, maybe I'll just ask our colleague Addis to see what we can do on that. And maybe if it's okay, what we could do is move along and see if we can resolve on David's audio, and I'll come to our colleague Carmen next. If that's okay, Carmen, I might come to you and we can discuss about the issues on self-care in humanitarian settings, and then come back to David to talk about some of the cost benefits and financing question. Carmen, if you're okay to step in,
That's fine.
Okay, great. I can just introduce you. And Carmen, we're really pleased to have. She's an associate professor with the University of Toronto in the Faculty of Social Work, and also the research chair in global health equity and social justice with marginalized population, and also working with the Ontario Ministry of Research and Innovation. This issue of self-care in humanitarian settings, a challenging setting to deliver regular services. We work on a number of these types of issues, but even more challenging to envision how we frame the issue of self-care. So Carmen, really pleased to have you with us, and over to you.
Thank you so much for the opportunity to be here. Next slide, please. Across the world, there was a record high 68.5 million persons forcibly displaced at the end of 2017 due to conflict, human rights violations, and natural disaster. 20 new people are displaced every minute, and this issue is growing. There are 1 in 110 people in the world displaced today, compared to 1 in 157 a decade ago. So in a humanitarian crisis, communities are disrupted so much they require national or international resources and help. And 85% of the world's displaced people are hosted in low and middle income countries. Sudden and protracted emergencies can lead to the collapse of healthcare systems in countries experiencing the humanitarian crisis and can strain health systems in host countries. This can result in insufficient and interrupted access to sexual and reproductive health services. Next slide, please. To reach the WHO triple billion goal, by 2023, 1 billion more people will be better protected from health emergencies. We need innovation for sexual and reproductive health care in humanitarian contexts. Self-care interventions for sexual and reproductive health may be particularly appropriate in humanitarian crises where countries might lack enough trained health workers and have unsustainable health infrastructure. Next slide, please. Let's take the example of Uganda, a low-income country that hosts more than 1 million refugees, the third largest number of refugees hosted in a single country in the world and the largest number in Africa. Most refugees are escaping violence in southern Sudan and are hosted in northern Uganda. That itself is a region recovering from a 20-year civil war. Between 2016 to 2018, the number of refugees in Uganda for every 1,000 residents tripled to 38. Yet, 2018 saw Uganda's lowest ever refugee response funding levels, In fact, looking at this chart here, which is UNFPA's Humanitarian Action 2019 Overview Report, you can see the incredible unmet need, not only in Uganda, but in many humanitarian contexts. UNFPA estimates here that they have received only 9% of the more than required $536 million in 2019 for global humanitarian crises. Next slide, please. There are challenges to meet sexual and reproductive health needs in humanitarian contexts. As you can see here, they include increased sexual violence, reduced health services, untreated mental health concerns, breakdown of family and community structures, and increased poverty. At the same time, there is limited evidence-based strategies to increase sexual and reproductive health service uptake in humanitarian contexts. There have been recent systematic reviews that point to knowledge gaps in research in these contexts regarding prevention of vertical HIV transmission, STI prevention, abortion and post-abortion care, and rape clinical management. We need innovative delivery models and research, and self-care interventions hold promise for these challenging settings. There is an interagency working group on reproductive health care and crises that developed a minimum initial service package, a MISP, for sexual and reproductive health and crises. Yet its focus on sexual and reproductive health, although it has not been systematically evaluated, aligns with many self-care interventions, including contraception, abortion care, and HIV. To address barriers in humanitarian contexts, an innovative service delivery model includes training lay health workers who may share experiences such as being displaced to promote and provide information about self-care to other refugees in the community. Thus, self-care interventions can provide the opportunity to increase lay health worker capacity and help to compensate for the shortage of formally trained healthcare workers. And HIV self-testing is an example of a potential self-care sexual health intervention in humanitarian contexts. HIV testing barriers among refugees include limited time and the priority of survival needs. And refugees, particularly youth, value privacy in HIV and sexual and reproductive health care. And so systematic reviews findings suggest that compared to standard testing, HIV self-testing may increase testing uptake and frequency. It could, in humanitarian contexts, reduce testing barriers such as stigma and privacy concerns and be more convenient than clinic-based testing. Yet the preferences for and feasibility of HIV self-testing is unexplored in humanitarian crises. Next slide, please. Before we implement self-care for sexual and reproductive health in humanitarian contexts, we have to consider the environment. We need to think about things such as antiretroviral therapy access and potential stockouts when planning ART adherence strategies. Where will we dispose of HIV self-testing kits and protected health information? What are the training needs, language barriers, and literacy among forcibly displaced persons in each context? Next slide, please. Intersectionality is a critical feminist theory that explores how social identities interact to produce experiences of power and marginalization. For instance, displaced adolescent girls can experience age, gender, and poverty-related inequalities that reduce healthcare access. And there's a scarcity of sexual and reproductive healthcare interventions in humanitarian context tailored for adolescent girls. Yet, such interventions such as over-the-counter oral contraceptives and HIV self-testing could potentially increase the autonomy of adolescent girls by reducing barriers to care, such as stigma, parental consent, and privacy concerns. And the priorities and needs of lesbian, gay, bisexual, transgender, and intersex or LGBTI people are also underrepresented in sexual and reproductive health research and programming in humanitarian contexts. So what are our ways forward? So the potential for self-care to augment sexual and reproductive health care in humanitarian contexts is underexplored. Self-care requires less infrastructure, can be scaled up easier than clinic-based approaches, and can reduce privacy concerns. Moving forward, we should consider intersectional approaches that address social and structural inequalities and understand how self-care preferences may vary by gender, age, and sexual orientation. The possibilities of self-care in humanitarian contexts are exciting and have the potential to advance sexual and reproductive health for over 68 million displaced people. And the final slide is where you can find our article and acknowledging all the co-authors. Thank you.
Great. Thank you so much, Carmen, for that super interesting framing of this. And in difficult settings and conflict and humanitarian settings. What I'd like to do now is just to try to come back to David and see if the audio situation is fixed and whether we can move on with David's slides. David, can you try to say something?
Yes, can you hear me?
Yes, perfect. That's wonderful. So just reintroducing David as our colleague from the World Bank, leading some of their global solutions work as well as work on the Decision Science Initiative, and partner for WHO for a long time, and really interested to be exploring this with you. So David, over to you.
Thanks very much indeed. And my remarks really build off comments that have been made before. And I just begin by emphasizing how much the world of self-care is expanding. And it's expanding very carefully and methodically in SRSH, and much more rapidly and often chaotically in wider fields such as NCDs. And we have over 17,000 discrete diabetes apps, to give one example. And in the wider field of digital health applications, it's also anarchic. And to take one low-income country example, Ethiopia alone has 300 different digital health apps, roughly half of which are completely proprietary and roughly half of which don't report to the Ministry of Health. So we really do need to make sense of this landscape, and countries need institutional capacity and use cases to better appraise self-care apps, as we've done methodically in the field of SRSH. And I think this is very clear for HIV tests, where they've been well regulated. It's less clear as we expand into fields such as diabetes self-care, for example. And as previous panelists have said, at what point do we need to ensure that self-care devices are regulated? For example, is the threshold biometrics? And if so, would that include BP? Is it diagnostic? And if so, at what level? We could all agree in vivo self-care will require regulation. But my key point is that we really need to either establish or expand our HTA, that is health technology assessment capacity. And increasingly, we'll need a DTA, digital technology assessment too. And if so, is that best done as part of an HTA, or is it best done separately? Let me turn to the financing of self-care and just lay out a couple of simple principles. Yes, we should certainly look at cost effectiveness, but it's really important to model and project future costs, as costs of innovations typically drop sharply as production efficiencies and economies of scale increase. We also have to factor in client satisfaction and the potential for increased impact. But the key to financing self-care will be to include it in health benefits packages, which are the core packages that underpin UHC. And so we need to ensure that cost-effective self-care technologies are included in health benefits packages, whether national, social, or private health insurance. And this is the key to making sure that UHC is operationalized and that self-care is included in that operationalization. But expanding health benefits packages either means displacing something that's already in the package or expanding the underlying financial base. Otherwise, it's a meaningless symbolic addition. In most cases, expanded financing is going to be necessary, and international financing can undoubtedly contribute, particularly in low-income countries. But much of the increased financing we will need will come from domestic resources, which will require many things, including economic growth, increased fiscal capacity, partly through increased revenue from the digital economy, increased allocations to health, and greater efficiencies in health. We also know globally that we spend $500 billion each year in out-of-pocket health costs, much of this inefficient and wastely. And if we can crowd some of this $500 billion into prepayment mechanisms and risk pooling, we can rapidly expand social insurance, including space for new self-care applications. Now, we want self-care devices to be free through health benefits packages. But I think there's also a strong case for parallel low-cost distribution through the private sector. In some cases, the opportunity costs of obtaining self-care from the public sector may outweigh the cost of efficient, accessible, local private distribution. And a last caution, which really echoes comments that colleagues have already made. To date, I think it's fair to say that digital innovations in general have largely benefited the cognitive elites, the educated, the skilled, and the mobile. And they'll undoubtedly benefit from an expansion of self-care. The excluded and marginalized may not. We have to ensure a constant equity lens, or we may exacerbate inequalities through expanded self-care. And as other speakers have eloquently said, self-care works best when people are strongly linked to human care in functioning primary healthcare systems where they need it. In short, as an adjunct to self-care. And in closing, thanks to Manjula and the entire team for this. Self-care is undoubtedly the future as more and more tests and devices become data connected, data enabled, and linked to cloud-based decision support and AI systems. So this is inevitable, but we have to manage it carefully with an equity lens and ensuring that we don't exacerbate inequalities or marginalization through its use. Thank you. Over.
Thank you so much, David, for that and for persevering on the audio. It is extremely important, this issue. And I'd like to turn to our last speaker as just we come up to the last sort of 15 minutes of our time here. And we won't have tons of time for Q&A, but just a reminder to enter your questions if you have any. We'll try to get to what we can at the conclusion. But I'll turn to our last speaker, Bethany Elmoth, who is Bethany is an associate professor at the Department of Biology and Environmental Sciences at the University of Gothenburg, Sweden, and has a background in a broad set of environmental and ecological areas, but particularly physiology and ecotoxicology, and works with interdisciplinary groups addressing environmental pollution. And one of the questions that we tackled in this was the impact of self-care and sustainability and safety, and she's going to address some of this. So Bethany, over to you for your presentation.
Yeah, thank you for that introduction, and I'd like to thank all the previous speakers who will make my talk a little bit easier, I think. So this is a summary of an article that we also published in this series in BMJ. Next slide, please. And I can also start by thanking my co-authors who were really a pleasure to work with. I can take the next slide. So we already had a bit of an introduction to this. The global market for self-care products is growing, and economically, financially, that's going to benefit the market. And much of this market will lie in Asia Pacific, which is really good news because there's a lot of people there. The populations are growing, populations are aging, the ones that are educated, they're gaining more access to healthcare and decentralized healthcare systems. But at the same time, these are countries that have, in many cases, a lack of a system to handle waste that is produced in their societies. So I'm going to get a little bit more into that in my next slide, where I would like to address waste management. So medical waste is regulated around the world, but currently about half of the world's population is at risk for medical waste from different kinds of exposures, occupational, environmental, public health threats. And this waste includes self-care products, but these are not regulated. So this is creating a problem, especially in areas where we have a lack of information about what is coming out onto the market, how it is being used, how it is being disposed of. Next slide, please. When we talk about waste, the major ways that waste is handled in societies around the world is through landfills or incineration. So landfills in places where you do have waste collection and management infrastructures, landfills can lead to problems with leaching of toxins and microorganisms into waterways. So this can be surface waters or groundwaters. They can also be dangerous to scavengers. So animals that are living in these areas, they can become impaled on sharps. They can ingest different types of plastics or metals or different materials that are causing internal damage. They can also be exposed to the chemicals that are present in these products. So the kinds of products that we're talking about contain thousands of chemicals, and the global chemical market is also very poorly regulated. So we have very little knowledge about how these chemicals are being used, what products they're in, where they're ending up in our waste management systems. But we do know that they can be problematic in the environment. There's evidence of pharmaceuticals affecting animals, affecting antibiotic resistance, there have been evidences of population collapses from pharmaceutical exposure in India and Pakistan, for example. The other way that we're dealing with our waste is through incineration. Incineration, in some cases, when it's done on an industrial scale, can lead to energy recycling. So we can use the high energy value of these materials to recycle it. It's maybe a cheating word to call it recycling, but energy recycling. But if it's not incinerated at proper temperatures in industrial situations, then we have a release of dioxins, which are building during the incineration processes, or release of other chemicals that are in these products, and they're coming into the air, which means that people are breathing them. We're increasing air pollution. There's a lot of particulates that are being released here. In many cases, incineration is done on a small scale or completely not regulated. So this is also increasing exposure through air. And this is increasing our carbon emissions, which is problematic. Next slide, please. When we're talking about human health impacts of plastics, and I focus on plastic here because this is one of the major materials that is used in a lot of these products, we can see that plastics are used not only in products themselves when it comes to sanitary napkins, tampons, condoms, but also packaging materials, syringes, all the pharmaceuticals that are being moved through blister packaging and primary, secondary, tertiary packaging. So this is a large amount of materials that we're talking about. They contain a lot of additives, and again, here, thousands of different chemicals. So there's evidence today that chemical exposure through plastics in human populations is leading to diseases on epidemiological scales. And this includes things like endocrine disruption in terms of metabolic hormones, reproductive hormones, thyroid hormones, leading to increases in the different sorts of reproductive cancers or diabetes, obesity, are some of the examples that we can have evidence for here. Microplastics are something that are discussed quite a lot with regards to plastic waste. We don't have a lot of information on how this is affecting humans, but we do know that plastics in the environment are fragmenting and degrading into these microplastics, which right now are found in virtually every environment on the planet. And there's also problems with waste management and dangers to waste pickers. So there's entire societies that are basing their income and their livelihood on waste picking and collecting materials that are usable and saleable on markets. This can include metals, but it can also include different plastic materials that go to recyclers. Waste pickers are in danger of being exposed to sharps or to other materials that are in these areas, but even to landslides, if you will, at dump sites or fires and things like this. Next slide, please. And the impacts of these materials in human health can also be indirect. So plastic materials or waste materials are known to increase flooding around the world by blocking drainage areas and rivers. This in turn leads to increased exposure to pathogens and disease propagation. So when you're in an area where you don't have waste management, oftentimes you also don't have proper sewage treatment facilities, and then you have a sort of a soup of pathogenic material. There's an increase in diarrhea through different viral and biological causes in areas, especially close to dump sites. You have a lot of waste. There's also in these materials, in these healthcares, you can have these products. You can have human biological material, which is a nice sort of breeding ground for human pathogens if you have blood or other human fluids. There's also evidence that these waste materials provide breeding grounds for malaria, which can increase exposure to malaria and Zika viruses. So there's a lot of both direct and indirect problems associated with the materials that are being produced and used on the market and how they're being handled in waste management facilities. Take the last slide. So here we can look at who the actors are that are involved in handling these problems. And this is where we really have to take a sort of interdisciplinary and transdisciplinary approach, because governments would be most responsible for ensuring that there's some sort of a solid waste management system. But in many cases, there are already systems in place that are informal sectors where you have different actors that are handling these materials. And these are not always regulated. So there needs to be some sort of accountability of where the materials, how they're being collected and where they're ending up. There should be focus on the materials that we're using. We can look at reducing, reusing, and recycling materials. So already in product design stage, we can look at how we could collect these materials and if they would be reusable again. Here again, it's important that consumers and communities are educated about what kinds of materials they're using and how they should be handled after use. We can look at interventions to change behaviors, both in access to the materials and how they're being handled, that they're being returned or destroyed in appropriate manners. Companies could definitely focus on looking at environmentally and socially friendly innovations. There again, including sustainable materials, choice of materials, looking at chemical usage. Here, there's almost no transparency in what chemicals are in products, and that will of course affect exposures for humans, for users, for the environment, but also the ability to cycle any materials that might want to go into recycling packaging materials, for example. And then we would have to have a look at different ways to influence policy decisions, the budget appropriation for different structures and infrastructures that are built in society. We need to have ways to monitor all of these systems to make sure that we're really minimizing the environmental impact and human health, the negative human health impacts of these materials, both for direct exposure and indirect exposure to the environment. And I can stop there.
Great, thank you so much, Bethany, for framing that. And I think we're almost to the top of the hour, but we still maybe have time for one or two quick questions that we've had. A few that have come up. Just one quick question that that maybe people have asked that I ask perhaps Manjula to jump in on. People made comments about the importance of pregnancy tests, and also, that this is this kind of issue on self-care is really important on rural care. Just if you want to make a quick comment on that, Manjula. And then secondly, to David, question on the price of self-care products, really who pays for this? And I think if you just wanted to make a comment on that, given your comments on UHC financing schemes, and as countries move forward, how this gets built in when you don't have a framework, how does this get paid for? So maybe Manjula, just a quick comment on the importance of pregnancy tests being mentioned here, and then how this could have an impact on rural care.
Yes, hi, thanks very much for that. I used the example of the pregnancy test because this was, pregnancy tests traditionally where, women would be able to access them, take the test, but would need to go back, to the health system to actually receive the result. This was, many years ago, but, that's how it was, because it was felt that, they may not be able to handle the result. And clearly now this is something that's available, in most places over the counter or relatively easily accessible. And so it is an example of an intervention that used to be really within the health system space and the health sector space, and that has really transitioned into that self-care space. And there are now many, many more examples of that. And as we move forward, having evidence-based guidelines, having a safe and supportive environment, and having that sort of the approaches that we have discussed, the various speakers have handled, is really going to be critical to provide the quality of care and meet those, both the national targets and the individual goals of people. Thank you.
Thanks so much, Manjula. And David, not to put you on the spot with our audio issues again, but the quick question on paying for self-care products, who does that fall on? You want to make a 30-second comment?
I can be very brief. I think it really falls on the architecture of UHC in each country, whether it's national, whether it's through social insurance, or whether it's through a combination of social and private health insurance. And the key is to get UHC included in and self-care included in the UHC benefits packages, and really to ensure that devices and approaches that are important for low-income people are subsidized and made as accessible as possible. Thank you.
Thank you so much for that, Paul and Manjula, but also big thank you to Paul and also Laura, Carmen, and Bethany for the framings here on a whole range of wide issues. I had a long list of questions personally, but we just don't have time. Luckily for you all, you can join the second of the 2 webinars tomorrow, Building the Evidence Base for Self-Care on SRHR, and we'll look really particularly on the evidence issues, which we just touched on briefly today and some of the other points. So with big thanks to BMJ and also to our organizers today, we will just remind you that the webinar will be posted on the HRP video library, and please visit the website and follow the group on